Okay. So it's a 70-year-old female. She is coming in with blurry vision in the left eye that started since cataract surgery 4 months ago. Her medical history is non-contributory, had an influenza immunization, pneumococcal vaccine, surgical history. She had endoscopy and cyst removal, systemic meds, just diazepam, allergies to a couple of antibiotics and iodine. Visual acuity is 20/32 in the right eye and 20/80 in the left. So here's a color fundus photo. You can go ahead, Khaled.
All right, it's color fronts photo of the right eye. Media looks clear. Nerve looks healthy, point like 3-ish. My attention is brought to the macula where we have this. Oh, okay. It has this paracentral white speckling. Looks like maybe even yeah, white speckling around the fovea basically.
I thought that was artifact. I don't know, Dr. Cohen, what do you think?
It might be a little membrane or drusen.
Yeah.
Now, a little white spot above, so this is, do you have this is an artifact here probably, but this may be a membrane, it might be some drusen.
Okay, so this is the left eye, and I'm gonna just go to the next one so that I can zoom into the area that we're trying to focus on there.
All right, it looks like a squiggly line. It's like a hypopigmented squiggly line in the it looks subretinal. I can see the vessels on top of it, and yeah, are probably some RPE atrophy there, but we'll see.
What else?
I think that was it. Also maybe the reflex is a little bit blunted as well, the fovea. You were thinking? Yeah.
This whole area looks like there might be food there. I don't know, right?
Well,
Maybe
OCT will disappoint you. Dr.
Maybe I-
Cooley.
So it looks like all the
choroidal vasculature is blocked out.
There's something making those inferior vessels elevated.
A squiggly line. He was.
This-
Not that squiggly line, like where the green area is down
Here.
there, yeah.
Oh yeah, more peripheral. It does look like it kind of keeps going on, maybe towards the ampulla or something.
You need to tell me it's not.
Go back to the zoom.
No, let's
Doesn't look like that whole area has,
looks elevated.
well, it doesn't look like there's the choroidal behind it. That's a normal retina.
No, there's chlorid there, but.
I'll tell you the fovea reflex definitely blunted.
I want to see an OCT.
Stand by this.
It is blunt.
Okay, so what is this? The IR of the right eye. Yeah, relatively normal. There's some reflective changes just around the inferior part, paracentral, but this is the left eye. There are some areas in that temporal foci that are hyper and hypo reflective respectively. Looks like the borders are hypo while the inner part's hyper in some areas. Doesn't really correspond to the shape that we saw on fundus photo. Kind of looks a little different. And then also in the macula, there's this little white, hyper reflective area as well, about like a quarter disc diameter.
Nice. This is OCT. There we are.
OCT, right eye, vitreous normal, foveal, it kind of seems a little sharp, the contour, but like are more acute. The angle is more acute than I would be used to. Otherwise, everything else looks pretty good.
Normal OCT there. This is the left eye.
Ooh.
All right, yeah, left eye. Looks like there's some cystic structures in the outer retina. Inner retina looks like it's relatively intact. Probably some shadowing from the overlying cysts in the center of, and then as you said, the foveal contour is definitely altered in this case.
Yeah, there's a little ear in there.
Okay, this is, what is this? I gotta zoom in.
Oh, can I see?
IR, OCT. No, I'm just zooming. I'm on my phone. So it's just IR and OCT. Okay, so I guess just the corresponding. So in that area off to the temporal side, we have the it looks like a superior inferior OCT of it looks like there's this sub RPE hyporeflective foci there.
Yeah, it's actually the choroid,
It's an elevation.
maybe an elevation or
Like a dilated
vessel
vessel.
there.
Yeah, dilated vessel or something in the choroid.
And this is like just a different, like a cross sectional there. You can see kind of.
So yeah, so it's probably like it looks like just a dilated vessel then. That would make sense. Especially with it kind of going radially like that.
Yeah.
Probably an aneurysm of some sort. This is the autofluorescence.
Yeah,
Right eye, looks pretty normal.
I agree. And then
Left eye, I don't know if that's artifact in the fovea, but there's some hyperautofluorescent parts in the fovea if that's not artifact, and then there's hypoautofluorescent lesions in the area of that possible vessel.
The fovea, that's what you expect with macular edema. So you get displaced, the macular pigment is in the axons of the cones, I think. So when you mess up your retina like that, you displace the macular pigment, so you get these funny looking things. It's a nice way to look at macular edema.
Okay, nice. So I'll just kind of scroll through this. So this is the right eye. It's pretty normal there.
And
And the left eye.
yeah, it looks like there's some sort of early filling defect in that area, and some blocking in the macula as well. And there's some I don't know if that's leakage or just staining. It looks like leakage is getting worse now.
I would have loved to have gotten an ICG on the patient, but they had a shelf.
Oh, I thought you were showing.
And that
that's
looks
not
like a petaloid pattern in the macula as well, so maybe some
Yeah,
CME.
And we're still going back and forth on the shellfish allergy. I think there's some question whether that's a real thing, iodine in shellfish, and so I think we're gonna stop making that a contraindication.
Didn't we talk about that at the Telling It
Yeah.
Negatives conference?
Yeah, what do you guys think? We're sort of moving away from it.
He said it's not real.
Yeah,
Yeah,
basically.
everybody seems to say it's not real. All right, that's what, who said that? At which conference?
Telling It Like It Is, Cataract General Conference in Tampa
In
a
Tampa?
couple weeks ago.
Just a little bit
Yeah, so
later.
just the
here.
same, there's some leakage, some more leakage in that area in the center, and then also out to the periphery, there's increased leakage. Looks
Yeah,
like it's
then-
filling.
Yeah, and then
Nerve.
what do you think of the nerve?
There's some peripapular atrophy. But it's
Usually macular edema that leaks a little, if it's inflammatory.
Is it leaking? I can't really tell.
So how about the other eye? What's the other eye show? So in the other eye, the nerve, that's your early late on the.
It looks
nerve.
about the same, honestly.
Yeah, I mean, it's staining. I don't think it doesn't look it's leaking to me, but it's kind of small. Yeah, it's a little bit more, but
A little bit more.
Yeah, a little
intense.
bit more.
Okay, so this one, has a little caveat. There's two things going on that are not related to each other. So there's kind of differential for the macular edema that you saw, and then the other thing that we saw about the temporal
sure.
macula.
Can you go back to the history of the patient? I couldn't quite recall the history here.
Yeah, so she had vision loss in that left eye 4 months after cataract surgery.
After
And
cataract,
she-
okay.
Yeah, she just had blurry vision.
Does she have a medical history of hypertension or anything?
No, there was no,
She diabetic.
it
Yeah, I'm
said
just
not.
trying Okay, non-contributory. Okay, so my differential Irvine gas syndrome after cataract surgery for that macular area. There's that dilated vessel outside as well, in the choroid, differential like hypertensive chorioretinopathy. there's, I mean, I don't know if maybe this undiagnosed diabetic retinopathy or undiagnosed macular degeneration. Yeah.
Nice, yeah, that's really good. So exactly, like pseudophakic CME, given that it's like right after cataract surgery, diabetic macular edema, retinal vein occlusion, hypertensive retinopathy, radiation retinopathy, and then AMD. And then for that choroidal lesion that we saw, choroidal macrovessel, parasitic infestation, so like if there's like a worm back there that look like that, choroidal tumors, vortex vein ampulla, retinal-choroidal anastomoses, diffuse unilateral subacute neuroretinitis, and anomalous posterior ciliary vessels is kind of what I found for like the differential for choroidal macrovessel. So we'll talk a little briefly about pseudophakic CME. So it's also known as Irvine-Gass syndrome, like you mentioned. It's one of the most common causes of visual loss after cataract surgery. The peak occurrence is approximately 4 to 6 weeks after cataract surgery. And the most common complaint is blurry vision, of course. They can also complain of esophageal scotoma, metamorphopsia, and mild photophobia. Clinically, the intraretinal edema, it's like an assist-like pattern and a honeycomb or like petaloid type formation in the fovea. And then on FA, like I said, so petaloid pattern of leakage into the parafoveal intraretinal spaces can be seen, and then the optic disc hyperfluorescence. Pseudophakic CME on OCT, it's you get the loss of the foveal contour, retinal thickening, and then the hyporeflective fluid cysts. So it's classified into acute and chronic pseudophakic CME. It's acute if it's within 6 months, and then chronic if it lasts like over 6 months. The incidence, thought this was interesting, so like as high as 60% if it's an intracap cataract extraction, 15 to 30% if it's extra cap. And then with phaco, there's like a wide range, like some studies say like 4 to 11, but then others said it can be as high as 41%. Like a little bit, I don't know, too much, but.
Well, some of that depends on what you're defining. So that's where you get this pseudophakic CME, you get stuck on, is it an OCT or is it
an FA finding?
Yeah, or or clinically significant. So the vision, my understanding is visually significant CME is like 2%.
Yeah.
And OCT finding maybe as high as 41%, but probably more like 10 or 20.
And it could be what kind of phaco machine they were using, like the original phaco machines were quite violent, right?
I don't know if that's changed that much. So that's the part. It's a lot of these complications haven't changed that much depending on the machines. I think a lot of these things have to do with the fact that you're putting, like retinal detachment risk has not changed much with the modern technique. I think what it is your natural lens is like a flying saucer and the intraocular lens are flat like a plate. And you're just changing the anatomy of the eye when you do cataract surgery, no matter how you do it. And that causes the vitreous to shift some, which I think in some people induces CME.
And so in chronic CME, pseudophakic CME, you have to think about other etiologies of the CME. So look for retained lens fragments. IOL malposition can do it apparently. And then Propionibacterium acnes infection, like one of those chronic indolent infections can cause it as well.
There was a good paper that just came out on this, and it was, I have it somewhere, but it was interesting. And if you do have a chronic, you have uveitic or CME post-cataract surgery, at a certain point, you just got to switch to uveitis. So and I had a patient who was sent, it was like 6 or 8 weeks, no, 6 or 8 months. And I just ran a uveitis planner and syphilis. And there was another syphilis patient, they're everywhere. And then there was, the paper was on B27. And they found that a 10 or 20 or 30, enormous percentage of them, although I have to say, I think B27 is positive in 7% of the population, so who knows what that means. But they have a fair number of B27 uveitis. And so once you get past like 3 or 4 months or not responding the way you think, I would run a uveitis panel on, which isn't much. I mean, just take syphilis, sarcoid. Did you guys do TB on all? Because there's some question about this. And then B27 CBC. It's interesting. I heard a lecture on uveitis from people that lived within I think practice within 50 miles of Lyme, Connecticut. And they both insisted they'd never seen a Lyme uveitis.
Wow.
It's like a total waste of money to get a Lyme test on a uveitis patient.
Lyme, Connecticut.
Yeah,
It's like,
that's where Lyme came from.
One of our residents did a study where he was looking at what's the yield of the uveitis panel we order, like
Right.
how often, and
Oh, that's good.
because we order all the tests in the ER.
Right.
So how often are these tests positive? Oh, it's never positive. And then he went over the cost per test. It was actually really interesting. The high yield ones for syphilis,
Right.
obviously, HLA-B27, and pretty much all the other ones were negative.
And then the thing
Always.
to compare it to is B27 in the population, which is really high.
Mhm.
So positive B27, like B27, there's something else in the population. Anyway, I'll find it.
And then I wasn't sure like what the mechanism of like an IOL malposition would be, like how does that correlate with CME?
Oh, because I would say, because usually malposition means one haptic's in the bag, one's out of the bag. So
Oh,
you're
that's
kind of getting
thinking.
into an Ugg syndrome. And you're getting the rub in the iris.
Mm.
So you look for transillumination. I have to say, I just started doing that. I asked Dr. Crane, had one of my patients, and she picked up the iris transillumination defects right away. When I was in training, we didn't have the big fat acrylic lenses. So I didn't get used to looking for that, but you guys should look for that. If you get the iris atrophy by the haptic, it's pretty obvious in transillumination. Then you can say, oh, it's probably a malposition. And it's hard to tell. I know very good cataract, especially new practicing, very good cataract surgeons, because the pupil's not that big. So you're doing a case, your pupil's not that big, you think you're in the bag, but you're not.
Okay.
And so it's tricky. And so, yeah, cataract surgeons, the expectations are so high, it's unbelievable.
A little bit about the pathophysiology of why it happens. So it's thought to be multifactorial. The major etiology, though, appears to be inflammatory mediators that are upregulated in the aqueous and the vitreous after surgical manipulation. So the surgical manipulation of the anterior segment triggers the release of the arachidonic acid from cell membranes, which leads to the production of prostaglandins, and that's via the COX and LOX pathways that we're well aware of. These inflammatory mediators affects the blood aqueous and blood retinal barriers and then causes them to leak more from the increased vascular permeability.
Do you notice your patients with really thick ERMs are much more likely to develop CME after cataract surgery?
Oh, even not that big. Yeah,
Yeah.
so big you see me. And there
That's
is,
the biggest risk factor.
there's some papers on that too.
You're saying thick?
Just any ERM,
Cocker can-
ERM.
and then, like I'll usually start them on a ketorolac prophylactically as well.
You
Compared
guys
to,
always get pre-op OCTs now? Seems
Yes.
like it really should be,
Yes.
cataract on everybody. Initially people were saying just for premium lenses, but it seems now the world's changed. It's just always, just to cover your body, nothing else.
oh yeah,
So, some papers I found on the prophylaxis for pseudophakic CME. So, topical NSAIDs are the mainstay, perioperative prophylaxis. For CME, there's been several retrospective reviews and prospective trials that showed that prophylactic use of NSAIDs reduces the incidence of CME. And that their efficacy is greatest when started at least 3 days before cataract surgery and then continued post-operatively for several weeks. But the exact timing and duration of the treatments, like, still not identified. More studies need to be done there, unless there's something that you know about Dr. Cohen that I didn't find exactly like the
Stuff is still-
timeline.
Yeah, the CME literature is challenging.
Mhm. And then this was interesting too, because I think I did see a patient that came from the community that came with bromifenac, that drop. We don't use it frequently, at least to my knowledge here at USF, but it showed that drop has like better penetration and efficacy compared to our like ketorolac that we're used to. And it's like inhibition of pseudophakic CME.
Yeah, bromfenac and the Pavfenac are both very good. They're just so expensive.
yeah.
It's like unbelievable, even generic bromfenac. And then Bromsite, there's Bromsite, Bromday, Brom this, Brom that. And they're like hundreds of dollars, but then occasionally there'll be some specialty pharmacy that'll get for 40, 50. So it's drops. You guys should write prescriptions, right? You don't have a specialty pharmacy you're connected with or?
No,
And when you
we
get
just
into
asked them
practice,
which
it's
ones.
kind of nice. Some of the practices, like there's a place in Pinellas Bailey's, which we haven't gotten to use yet. I wish we would. But I'm the doctor to be able to, like, I just haven't quite got the energy. But we give them prescriptions, I'm gonna go to Walgreens. But some of these pharmacies will work out deals for your patients. They ship it. It's so nice. So a number of the busy cataract practices, patients can have cataract surgery, the patient, they send a prescription to the specialty pharmacy ships this stuff to the patient, so they have it, you know, they don't have to go to the pharmacy to pick it up. And most of them are outside of insurance, like 60, 70. Have you done the combo drops?
Yeah, a lot of the combo drops have Brontenac.
Yeah, the combo
The
ones, those
Brontenac
combo
ones,
drops will be
right.
60, 70 bucks, and that's not bad, and that way you're not dealing with insurance and
Nice.
really nice.
Okay, so a bit on the treatment. There's a lot of treatment options out there, but main one that we've seen is the combination therapy with prednisolone and ketorolac. Then there's corticosteroid injections. There's a debate on subtenon versus intravitreal. Acetazolamide, there isn't like much data to support the treatment of that with pseudophakic CME, but it's been used before with like CME related to RP and epiretinal membrane formation apparently. So I've never seen anybody use that, but that was something that I've come across. And then anti-VEGF, the theory is that it can, you know, decrease the vascular permeability. I've also never seen that used with pseudophakic CME. Laser vitreolysis, if there's any vitreous in the AC that could be causing like, I guess, some traction and then resulting CME. And then lastly, vitrectomy, you can do as well.
One fun thing, the laser vitreolysis does have a code. So that's what people use for laser for floaters. So when you see all these people advertising laser for floaters, they're using the vitreolysis code, sort of coding it on,
So wait, they're billing people's insurance for it, or they're paying, oh, wow.
that
Interesting.
you can do.
That's not medically indicated, right? It's not.
Well, there was a paper in JAMA Ophthalmology 5 or 10 years ago that was randomized, that showed a slight benefit to people with Weiss rings. It was a specific population. So you had to have like a giant Weiss ring kind of anterior vitreous, and they seemed to benefit. My understanding is the first author on that paper doesn't do it anymore.
Yeah.
But because that paper's out there, you can justify doing it. And most patients, but some, I've had nobody benefit from it.
Lasering vitreous sounds sketchy, like it just
Yeah,
sounds like you can.
I've had people hit the
contract.
retina. I've seen
Say
people
this,
hit the retina.
the closer
Well,
you
the
get to
idea is if
the
you see
retina.
one strand, like a windshield wiper strand, you can pop it with the YAG, and then it'll drop out of the way, just like you're doing the YAG caps on his anterior. But some people, like, there's a guy in Sarasota who's the biggest one, I think, in the country. And if you Google laser for floaters, he'll come up. And he called me once about a patient. And he said, oh, what did he say? He charges $2,000 a treatment. He said, and he goes, I've done 10,000 of these treatments and I've never had a retinal detachment. And all I could think in my head was 10,000 times 2,000. It's 20 million. And like, I lost the rest of the, I don't know what he said.
Yeah.
I just kept thinking, $20 million.
We're just shitting some laser.
They all have websites like gagmyfloater.com.
Right,
and
right.
like,
So,
yeah.
and I don't remember the patient or what he said. All I remember was that one comment that I'm always doing math in my head and just like, it picked the number out. I was like, oh my gosh.
And it was in Sarasota.
Yeah, it's a big one in Sarasota.
So what, briefly about the choroidal macrovessel, because that was an incidental finding with this patient. So it's a rare anatomical abnormality reported in the literature in fewer than a dozen reports is what I found, consisting of a vessel in the choroid with a larger diameter and a more pronounced tortuosity than the surrounding vasculature. It's described as a hyporeflective lesion occupying the entire thickness of the choroid, like we saw in our patient's OCT, along with the elevation of the overlying retina and posterior displacement of the choroid scleral junction on the EDI OCT. There's early filling without fluorescent leakage on ICG. It suggests the arterial nature of the vessel. And then OCTA is diagnostic for the choroidal macrovessel.